Welcome back. Today we will discuss the evolution and revolution, really, especially in the San Francisco Bay Area, of a movement called microdosing of psychedelic drugs. Now, there is also a counter idea, namely that it requires a mystical experience, an experience out of the ordinary that has a number of criteria in order for the salutary, the healing effects of psychedelic drugs to really manifest. We will put this into a different framework, namely the antidepressant mechanism of psychedelics. A recent paper has appeared which speaks to the biochemistry, really to the molecular biology as well, of the psychedelic effect on brain circuitry, perhaps or likely mediating its antidepressant effect. So here then is the paper. Psychedelics promote structural and functional neuroplasticity. A paper that's just recently appeared a few weeks ago. So we will now begin to put this into a context, namely the structure, resemblance of psychedelic drugs to existing compounds. This slide, namely norepinephrine and mescaline. You can see the norepinephrine molecule is quite intact almost here if you compare it to the mescaline molecule, which has a couple of 3 methyl groups attached to the indole ring structure. Now, mescaline is the drug that Aldous Huxley was given and that he described so vividly in his book, The Doors of Perception. When I was a young medical student in Hamburg in the late 1960s, somebody, perhaps in a pharmacology class, put the structure of norepinephrine on the blackboard and contrasted it with the structure of mescaline. And that similarity, that profound difference induced by a few methyl groups in terms of the phenomenology and the pharmacology, the powerful effects that this slight chemical substitution had, moved me into getting into psychiatry. This one figure on the blackboard determined really the rest of my professional life, and I thought I'd put this up here so to introduce you to mescaline and also to that event that brought me here to making this video many, many years later. So here is Aldous Huxley and his book, The Doors of Perception. In fact, he was introduced to mescaline by Humphrey Osmond, and he then wrote the famous book, The Doors of Perception. Psychedelic is a name that these two people came up with, meaning mind manifesting, from psychos and delos, 2 Greek terms combined, indicating that these drugs can show you what your mind is capable of and let you have access to the recesses of the mind. So here then is what Aldous Huxley had and what many believe is required for psychedelic drugs to have the powerful effects on man in terms of alleviating depression, for example. Namely, a mystical experience consisting of feelings of unity, sacredness, ineffability, being at a loss for words. There is just nothing in the language that is commensurate with the experience. Peace and joy, as well as an impression of having transcended in some way space and time, and a so-called noetic sense, the feeling that something was disclosed about a truth, about reality, that is also difficult to put into words, but has a very powerful convincing effect, that this disclosure is at once personal and yet of universal significance and may very well shape the rest of the course of your life. So a true mystical experience then needs all 6 of these characteristics. And this has been then incorporated into some rating scales in research having been done at Johns Hopkins by Roland Griffiths, who wrote a pathfinding paper in 2006, which opened the doors, not of perception, but the door of reintroducing the psychedelics into legitimate university-based research. Now, our focus is on depression. And as it happens, microdosing has been going on for a very long time, namely with a drug called ketamine. Many of you may have heard the ketamine story. The one drug in psychiatry that can alleviate profound depression, even treatment-resistant depression, within some hours, not in days or weeks. It can also abolish suicidal ideations within minutes or hours. Now, the ketamine story really is a story of microdosing, because the doses used in ketamine studies are all sub-anesthetic and sub-dissociative. In other words, you're not supposed to feel anything. You're not supposed to have a experience of any psychedelic or other kind, or not experience psychotic symptoms to any extent, but you're flying in under the radar. And what happens is that profound things happen at the biochemical level that we will discuss shortly, and then contrast with those produced by psychedelic drugs. Now, let's define depression. Depression as a loss of dendritic spines and dendrites as a hallmark of depression and other neuropsychiatric disorders, especially in the prefrontal cortex. So that's our definition. And anything that improves the functional capability and anatomical integrity of dendrites and dendritic spines, we would predict has an antidepressant effect. So here then is an illustration. On the left panel you see the effect of chronic stress as it causes atrophy of neuronal processes and a decrease in synapse number. Now the left side of the panel shows you the 100 micron scale here, so you will see the entire cell body and the dendrite arborizing on top. And on the right hand side you have a 5 micrometer scale, so that is diving into the substructure of the dendrite, and you're looking at dendritic spines, those areas that are so critical in communication with other dendrites and in synapse formation. This is where computing, this is where the business end of the dendrite is located. And you can see that in the control you have a bunch of healthy bubbly spines, and on the right hand panel you see that the spines have been decreased in number and don't look so healthy. So we then define depression as a disease, a decrease in the number of neuronal processes or dendrites and in the number of dendritic spines. This is the summary sketch on ketamine. So we have ketamine being administered. Presumably it interacts with the NMDA receptor. These receptors are all over the cortex, just like the 5-HT2A receptors for serotonin are all over the cortex. And it's thought that the binding of ketamine then inhibits the NMDA receptor, and in some indirect mechanism releases a volley of neuronal activity, triggering the entire cerebral cortex, kind of like an explosion of excitatory activity. And as a result of which, we get increased spine density. And you see in the middle here the red marker mTOR. We will unravel this and explain to you where this came from and what this really means. So microdosing then, sub-dissociative doses of a compound in depression, has been around for many years and predates the renaissance of the psychedelic third wave, as it's called, the re-emergence of psychedelic research in respectable research centers. So here we do a deep dive into the synapse where ketamine is supposed to act. On the left-hand side, you see glutaminergic neurons, those neurons which are the most predominant excitatory neurons in the cortex. You see all the wonderful things that are going on after glutamate binds to either the AMPA or NMDA receptor. Namely, there is a release of brain-derived neurotrophic factor, which leads to increased production of vesicle cytoskeleton elements and those that are required to keep the neuron healthy and to have it functional. Now, with prolonged stress on the right-hand side, you can see that the number of receptors have shriveled. And this is in part due to the fact that those growth factors, B and DF, have not been properly produced. Something is missing in the cascade. Synaptic proteins are not made, and we are winding up with a shriveled and incapacitated neuron. In comes ketamine in the next slide. And you can see here by blocking the NMDA receptor, you have an indirect effect on the neuron, which leads to massive increase in firing rates. AMPA receptors are activated, and again you see the mentioning here of mTOR, which we will elucidate in a second. So ketamine is believed to cause a burst of glutamate. This is thought to is via disinhibition of GABA interneurons. The tonic firing of these GABA interneurons is driven by NMDA receptors. So by blocking the NMDA receptor, you release the inhibition from GABA neurons and you cause a global burst of these neurons in the cortex, leading to activation of all kinds of cellular processes that keep the neuron healthy and leads to intact dendrites and dendritic spines. Now, the next slide, we go a little further and focus our attention on this entity called mTOR here in the green box. And you can see there are many ways to get to mTOR, but one way is through the firing of the GABA system. Now, ketamine can inhibit this mTOR activation. You can see here there is a tyrosine kinase which talks to mTOR. The function of mTOR appears to be a control of various metabolic processes that lead to the production of those structures and proteins in the synapse that are required for normal functioning. The next slide, you see what stress does. You see glucocorticoids in the red box bind to the glucocorticoid receptor, which can translocate into the nucleus and inhibit mTOR. We have talked about the epigenetics in the previous lecture on the glucocorticoid system and the control of the glucocorticoid responsive gene and the number of glucocorticoid receptors being critically involved in dampening and modulating stress response. So here again you find this player mTOR being intimately involved with stress responsiveness, and as a result of being shut down or modulated, you see a decrease in production of those neuronal elements, including glutamate receptors, which should be required to keep the neuron healthy and functioning. So that's our groundwork for ketamine and our basis to evaluate the psychedelics for their antidepressant efficacy. Now, in order to understand microdosing, we need to do a brief historical excursion. Here is Dr. Jim Fadiman, who wrote a book, The Psychedelic Explorer's Guide. And in this book, he mentions the possibility of using psychedelic doses of, for example, LSD at 10 to 20 micrograms per every fourth day or so rather than a full psychedelic dose of 100 to 150 or maybe even 200 micrograms, triggering a full-blown psychedelic episode. Nevertheless, microdosing has been described by many of those who've tried it as being very effective in alleviating depression, anxiety, increasing focus, attention, and general well-being. Now, as a warning, there are no controlled trials of microdosing that I know about that have demonstrated its effectiveness. But all this is speculative and based on anecdotal reports. However, there is a parallel here to the ketamine microdosing, and now if we can demonstrate that psychedelics tap into the same biochemical pathway that ketamine does in order to produce this antidepressant effect by stimulating dendrites and dendritic spines, then we may have a story here that is worth pursuing. So here then is a couple. This is Ailette Waldman and her husband Michael Chabon. And both are accomplished people. He is a novelist, a Pulitzer Prize winning. She is an attorney and a novelist, among other things. And she described that she was depressed, seriously depressed, and even suicidal at one point in her life. She was so profoundly depressed that she looked through a medicine cabinet and checking out what might be available in sufficient doses to kill herself. It was at that time that the Jim Fadiman's book, kind of accidentally fell into her hands. And she discovered the literature on microdosing. And she describes in a book called A Really Good Day how she used this technique to pull herself out of the depressive episode with microdosing. Interestingly, there's also a brief video which we will show you now. So you meet Ailette Waldman here in action, and she can tell you a little bit about her experience with microdosing.
The microdose, when we're talking about psychedelic drugs, is typically a 1/10 dose. If 10 is a microdose, then 100 is a psychedelic dose. So in LSD, the typical psychedelic dose of LSD is 100 micrograms to 200 micrograms if you're really, really aggressive. And a microdose is somewhere between 10 and 20 micrograms. So the idea behind microdosing is that it is designed to be sub-perceptual. You don't want to trip. If I said to you right now that I had given all of you a microdose, none of you would really have noticed that. You might just, hence the title of my book and my talk, at the end of the day you might think to yourself, wow, that was a really good day. But you wouldn't see things burst into bloom. You wouldn't have kaleidoscopic colors drifting through your field of vision. You wouldn't necessarily feel that sense of oneness with the universe that we're talking about so much over the course of the past few days. I read about this microdosing, and suddenly, for no reason that I can really explain, I decided that I wanted to try it. There were other options open to me at that period of deep depression. I could have tried electroconvulsive therapy. I could have tried ketamine. I could have checked myself into a hospital. But microdosing seemed to me like an option that I really wanted to explore. But I was still afraid. So the first thing I did is I called Jim Fadiman out of the blue. I was probably one of 100 people who'd called Jim Fadiman out of the blue that week. But for whatever reason, he picked up the phone. And we spoke, and I had this incredible sense that this was a person whose experience and expertise I could trust. In the 1960s, Dr. Fadiman was a psychedelic researcher, initially at Stanford and then at an institute here in Silicon Valley. His area of interest was particularly the effect of psychedelic drugs, specifically LSD, on creativity. And he did lots of research with people who went on to become pioneers in various Silicon Valley businesses like the emerging computer industry, bio researchers, architects, all sorts of people who became pioneers and sort of had a creative spark in what later became the kind of emergent businesses of Silicon Valley. And what Dr. Fadiman did is he gave them psychedelic drugs, and they had and asked them to bring problems to intractable problems that they had been working on in their labs, in their offices, to the experimental room, and then they would work on those problems under the influence of LSD. And they had remarkable insights that I'll talk about more later. But Dr. Fadiman and I talked about LSD, and we talked about this creativity research, and we talked about the research that was going on at Johns Hopkins and NYU and UCLA Harbor using psilocybin and other psychedelic drugs that operates very similarly on the brain as LSD to treat intractable depression, specifically depression in people facing the end of life, and the remarkable results that we were starting to see there. And I grew more and more comfortable with what had, even before this phone conversation, been a very terrifying thing to me. And I decided, okay, I'm going to give it a try. Right now, I want to kill myself. It can't get worse than this. And I live in Berkeley, California, so I thought that wanting to try LSD meant that I was going to just sort of, I don't know, walk out on the street and orange sunshine was going to rain down into my cupped palms. It never occurred to me that it would be difficult in Berkeley, California to find acid. But I am a middle-aged, middle-class mother of 4. And the Venn diagram of LSD users and my middle-aged, middle-class mom of 4, there's no Venn in that diagram. So Dr. Fadiman urged caution, and he told me that it was important to be circumspect in my search for illegal drugs and to be quiet. And that did not work for me. So eventually I just started asking everybody I knew if they could get me some acid. Like everybody. Except my teenage children, who were probably the most likely to be able to get me some acid, but I couldn't go that far. So I asked everybody I knew. Everybody said no. Anytime I heard that someone had been to Burning Man, I tried to get invited to the same party. I know those people had it, but they looked at me and they thought, we're not giving it. No. And then one day I was at a cafe where I like to work in Oakland, and another person working on their type, we sort of struck up a conversation, and I asked him, because what the hell, by then I was asking total strangers. And he said, I heard about this microdosing thing, and I heard about a professor somewhere in the Bay Area, I'm not sure. And this professor has been microdosing for decades. And my understanding is that he's at the end of his life, and maybe he has some extra acid. That didn't seem at all to make sense, but because by this point I had lost all sense of judgment, I happily gave the guy my address and told him that if he ever met the professor to, see if the professor might send me some. And 2 weeks later, I went out to my mailbox, and there was this little package festooned with the most brightly colored stamps, all sorts of different stamps, old stamps with prices on them, like from before the forever, the exact kind of stamp an elderly professor might have in his bottom drawer. And the return address read Lewis Carroll. And inside was a little bottle, that little cobalt blue bottle, and a poem, and instructions for use. And I'm not crazy at all. Well, yes I am, but not. I have a certain amount of good judgment, and one of the things that I always tell my children, because I did drug policy reform for so long, I have a harm reduction approach to using drugs with my kids, and the thing that I always tell my kids is you have to test your drugs. I don't actually care what you take as long as you test it and know what you're taking. It's most important to me that you don't die. So when they go out the door on their way to a party, I shout after them, use a condom and test your Molly. So I decided I had to test the contents of this little blue bottle, of course, because I'm a responsible person. I only, got it from some stranger, and who knows where I got it. So I ordered an LSD testing kit. Does anybody have a guess from where? Exactly. Say it again loud. Exactly. I ordered my LSD testing kit from that purveyor of toilet paper and deeply discounted books. I tested my LSD. I made sure that what I was taking was, in fact, LSD and not something else. And I put those 2 drops on my tongue. And I was very nervous, even though I had done all my research, and I'll tell you all about that later on. Even though I knew that this was a safe drug to take, I was very scared. That inside of my head, it wasn't a place that I was really comfortable exploring. I sat down and I waited. I waited for the colors, even though I knew that it wasn't going to happen. I waited for that bad trip, even though I knew it wasn't going to happen. I waited for Lucy in the sky with diamonds and the yellow submarine, even though I knew that wasn't going to happen. And nothing happened. And so I got my laptop out and I started working because, I have books due and scripts to write. And I started working and I just was sitting at my desk doing what I was actually at the kitchen table doing what I normally do. And at some point I lifted my head and I looked out my window. And there was a tree, a Japanese maple out in my garden. It was the dogwood, sorry. It was a dogwood tree, and it was springtime, and the dogwood had gone into bloom. And I looked at the dogwood, and I said to myself, look how beautiful those blossoms are. Now, it wasn't like the blossoms were flying around in space. There weren't kaleidoscopic colors, but it was just that I had been anhedonic for so long. I had been so devoid of the capacity to experience pleasure and experience beauty that I forgot what it was like to look at a beautiful blossom and say, that's beautiful. And suddenly I felt it. And it was really that dramatic and that instant. I went from being suicidally depressed and unable to experience joy to looking out the window and finding myself exhilarated by beauty.
Okay, so you now know that Ailette Waldman had a good experience with microdosing. Before she did this, a number of research studies, particularly from Johns Hopkins out of the lab of Roland Griffiths, have put the psychedelics back on the map as being important compounds in looking at depression. Now, these were studies that were approved by the FDA. Waivers have been granted to obtain the psychedelic drugs because all of them are Schedule 1 by the FDA. Now, Roland Griffith is an extremely well-respected researcher for many years at Johns Hopkins, and he had the street cred and the gravitas to be able to get this through. And he shows that psilocybin can improve depression and anxiety in perhaps the most difficult clinical situation known to man, namely patients facing life-threatening cancer, which is often associated with profound depression, anxiety, and existential angst, which there is nothing in psychiatry that really can assist these folks. And this group at Johns Hopkins has found that psychedelic doses of psilocybin, for example, can, in many patients, dramatically, within a day or so, reset their expectations, their acceptance, their mood, and decrease their anxiety, making the dying process much easier and transforming really not only their remaining life, but also transforming their death. So this is then the clinical background that we're dealing with. I'll show you now a result here from Imperial College London, where Carhart Harris, the leader of the psychedelic research group at that institution, has also done a study on treatment-resistant depression. Now, they selected patients that had been depressed for 10, 20 or more years, had tried up to 11 antidepressant medications, and just were totally at the end of their rope. Nothing really had worked. So these patients also were given a psychedelic dose under careful conditions with a guide, a psychotherapeutic guide. There was psychotherapeutic preparation before the psychedelic experience. There was a guide present during the experience, and there was sessions afterwards to integrate the meaning of the experience for these patients. And you can see that there was a profound decrease in the level of depression in many of these patients within a day or so. There's nothing in psychiatry that has ever achieved this kind of immediate response. And it's rather striking that we're sitting on this gold mine of this powerful tool, and academic psychiatry, with the exceptions of a few centers, is not really doing anything about it. Ketamine is slowly making its way to the clinical arena, but who knows how long psilocybin or LSD will take to be rehabilitated to such an extent that it can make its way into the clinic and help profoundly depressed patients. Truth is that our antidepressants are lousy drugs. Only a fraction of our patients respond to them at all, and if so, usually not to the extent that they are in full remission for any period of time. In the next slide, you see another presentation of the data. It was a small group of patients, so it can only be considered to be a pilot study, but you can see that the effect was lasting for several months. The other thing that many groups, Johns Hopkins, NYU, and Imperial College of London observed is there seem to be profound personality changes in patients who have undergone a profound psychedelic experience. Namely, the measure of openness, the personality trait of openness, seems to have been permanently changed, increased, which is of course considered to be a very positive event in a patient's life, and had heretofore been considered totally impossible to change a personality trait with a single administration in the psychotherapeutic setting of a psychedelic drug. So let's discuss now, how does this stuff actually work? Well, you all know that psychedelics bind to the serotonin receptor, namely the 5-HT2A receptor in the cortex. And in this picture you see that the entire cortical surface is red here, indicating the high density of these receptors. These receptors are in those cortical areas that are most critical for integrative function, the frontal cortex and the association cortices, in which we do our thinking, our concept formation, our monitoring of our self-concept, and other higher powered functioning such as this. And you can see here again, these compounds stimulate structural plasticity by activating the mammalian target of rapamycin. So I think it's about time that we get to unpack what this is. Here then is a study that was in the first slide, and which we will discuss in a minute. You see here a number of psychedelic drugs of different families, namely from the amphetamine family, the tryptamine family, and the lysergic acid family. So these are three different families that have been modified. They all bind to the 5-HT2A receptor, and it is likely but not conclusively shown that then the end result is a massive glutamate release, triggering glutamate receptors, just like in the ketamine case, and that then leads to the production of brain-derived neurotrophic factor and increased neuroplasticity. So that is the theory. In the next slide, here we have mTOR, to whet your appetite one more time. So mTOR is a mechanistic or mammalian target of rapamycin. It was discovered in 1964 on the island of Rapa Nui. We know it as Easter Island. A group of, I believe, Canadian researchers went to distant areas of the planet to find virgin soil samples to discover bacteria and evaluate them for the utility for pharmaceuticals, in particular antifungal medication. So here is, of course, the iconic picture of Easter Island. And in the soil of this island, a bacterium was found which produced a antifungal agent named rapamycin. Rapa from the first syllable of Rapa Nui, and mycin for antifungal. So this compound was found to be antifungal, but it also had strong immunosuppressant effects. That was at that time considered very undesirable. The compound was shelved and was forgotten about until it made an appearance much later. So here, the milestones of research on rapamycin and mTOR. A group in Basel, Switzerland became very interested to identify what is the target of rapamycin, how does it do its antifungal activity, and they worked with yeast. Now yeast is a wonderful organism to do genetics with, and you can do genetic screening very efficiently and identify mutants that are resistant to rapamycin that then allow you to home in on the rapamycin target. Once this was accomplished, the target in mammalian cells was identified, and then of course a slew of other activities took place here. Most recently, of course, the involvement of mTOR, or the mammalian target of rapamycin, in neuroscience, namely the production and maintenance of growth factors in the neuronal cell. The key effect of mTOR in bacterial and mammalian cells seems to be cell growth, not cell division, but rather making those elements in the cell that allow the cell to grow in size and make those components and machineries that are necessary to expand cell volume. So in our case, of course, as a neuron grows, one of the likely outcomes will be the growth of those extensions of the neurons, such as dendrites and the spines and the apical dendrite. So here then is TOR as a universal controller of cell growth, protein synthesis, nucleotide synthesis, lipid synthesis, on and on. All this is controlled by mTOR. There are some specific disorders linked to dysregulation of mTOR signaling, such as cardiac hypertrophy and tuberous sclerosis, and perhaps some cancers. And here are some mTOR signalings in obesity, and I think we might want to add depression as a possible mechanism that is mTOR related. Now, let's get back now with all these preambles to our target paper. So here we have the so-called psychoplastogens. Now we have psychedelics, so the authors of this paper suggest a new term, psychoplastogens, namely psychedelics that increase neuronal plasticity. And they all do this by increasing spine density and the density of synaptic connections that are a result of the same. So here then is the key result of the paper. Here's the number of branches in the neurites, the spine processes. You can see that compared to the vehicle, DOI, which is the amphetamine-derived psychedelic, the DMT, the tryptamine-derived psychedelic, and LSD all increase the number of branches in these spines in a very powerful and substantial way. In the next slide, you see looking the spinogenesis and epigenesis and functional plasticity, with LSD here being the leader on the left-hand side, DMT and DOI all being very effective. And you can see that the growth of these spines and synaptic processes is quite remarkable. The next slide, you can see that synaptic markers, both presynaptic and postsynaptic, are increased. And you can see that on the right-hand side that new synapses, in fact, are being formed as a result of exposure to these three psychedelic drugs in vitro. Here you see a quantitative aspect of this, the synaptic density, synaptic size, the density of the vesicles for glutamine is increased, as well as the postsynaptic density, PSD95, a marker for the postsynaptic membrane, all are increased in a uniform kind of a way, giving you the picture of a massive growth spurt of all components of dendrites, dendritic spines, presynaptic and postsynaptic components of the business end of computation in the cortex. The next slide shows you a very nice picture of the spines and the spinal processes here on the apical dendrite. You can see that DMT on top and at the bottom, the apical and proximal dendrites are showing explosive growth, especially the dendritic processes on exposure to DMT. And the next slide, this has consequences for the firing rate of neurons. So you can record from neurons, from the pyramidal cell neurons in slices obtained from animals exposed to DMT, and you can see that the firing rate on the right-hand side here is significantly increased in those neurons that have been exposed in vivo to a dose of DMT. So not only do you produce more of the components of presynaptic terminals, dendritic spines and processes and postsynaptic densities, but you also produce the resulting increase in the firing rate, speaking to the idea that a global increase, a massive increase in firing pattern through these cortical neurons is underlying the effect on the depressive symptomatology and producing those components in the neuron which tend to be associated with a healthy functioning cortex. Now, how about mTOR, of which we made such a big deal? Well, if you associate your experiments and you pre-treat the preparations with rapamycin, you can see here that rapamycin abolishes the effect of psychedelic drugs on the effects on the spine and the dendrites that we have discussed previously. Basically, the effect is flattened out, strongly suggesting that in some way, mTOR, this critical component of cell growth, is involved in the effect of psychedelic drugs. So then, in summary, what we can say is that psychedelics from 4 different structural classes, the amphetamines, tryptamines, and ergolines, iboga as well, are potent psychoplastogens. In other words, by binding to the 5-HT2A receptor and being psychedelic, they also terrifically increase acutely plasticity at the neuronal level. So although the molecular targets of ketamine and psychedelics are different, namely the NMDA receptor and the 5-HT2A receptor, respectively, they appear to cause similar downstream effects on the structural plasticity by activating mTOR. So there is a long-standing debate in the field now concerning whether the subjective effects of psychedelics are really necessary for the therapeutic effects. In other words, do you need a mystical experience to benefit from the antidepressant quality of psychedelic drugs? Now, people experimenting in microdosing would say, no, you can take microdoses which do not affect your daily functioning, except perhaps increase a sense of concentration and well-being, but you still benefit by decrease in depression, as evidenced from a Let's video that I showed you earlier. Now, what then about a psychedelic dose with a mystical experience? Well, it's possible that at a massive dose, you increase the penetrance and the extent of the glutaminergic discharge-induced processing and synaptic plasticity, that one single shot may last you a lifetime in a sense. That is such a massive organization, which of course also goes along with massive interference in your life and perhaps some associated risk. So in my view, we can say that small microdoses of psychedelics will introduce synaptic plasticity in the same way as ketamine, which has been shown to be a powerful antidepressant. Now, ketamine is not so easy to administer, and I think that microdosing is a much more likely solution to many chronic depressive patients, because used at 10 micrograms or 15 micrograms every 4 days without any psychological effects may keep you in remission from your severe depression. So hopefully research can demonstrate that in a double-blind fashion, which should be easier to double-blind than a full-blown psychedelic experience. Everybody knows when they got a psychedelic, and everybody knows when they didn't get it. With microdosing, you would never know. You would hardly feel any different in terms of the altered perception and altered state of consciousness. So it might be much easier to prove efficacy in depression in the microdosing paradigm using double-blind technology. So thank you for your attention. I hope you enjoyed this somewhat deep dive into psychedelics and their antidepressant properties, which hopefully will come to market within my lifetime. Thank you for your attention, and we'll see you soon at Behavioral Health 2000.